Hello, Clinic Review family. Today I'm going to be talking about pre-op and post-op. We're going to be doing straight NCLEX style questions to practice them. So let's go ahead and get started. Hello, my friends. It's Dr. Sharon with Clinic Reviews. You know, this channel is a part of the greater Clinic Review organization where you can go to clinicreviews.com and you can get a streaming service. You can get small group tutoring, a monthly service. You can pay for a month's worth of small group tutoring. It's very, very good. We do next gen and we do prioritization and delegation. And so you can get practice with those. That's really important. And then you can also sign up for the clinic review itself, the 21 hours of NCLEX prep, which is not something we focus on. We don't focus on the content from the clinic review here. So you can sign up for an in-person with Mark, or you can do the online on-demand NCLEX prep, which is very, very good. So let's go ahead and get started doing some of our questions. There's not really any content for me to teach you on specifically. So let's just do some questions. We'll practice some strategies as well as making sure you know what you need to know about this. A client with type 2 diabetes is scheduled for a colon resection. During the pre-op assessment, the nurse notes the client's fasting blood glucose is 220. What is the best action by the nurse? All right, so they're type 2 diabetes. 220 is pretty high, usually over 200. We want to do something about it. But the question is, it doesn't tell me I have any standing orders. At least maybe there'll be some answers that tell me I have standing orders. So I think, well, they probably don't want to send him to surgery with a blood glucose of 220. It's just a thought, because surgery is a stress on the body and the body's going to release stress hormones. So the blood sugar could go up a lot higher. So I don't know. I'm thinking I at least need to call the doc and see if we want to give him some insulin. Let's see what we've got here. Notify the surgeon and prepare to administer insulin. So maybe that sounds okay if there's no better answer. B, proceed with pre-op prep as planned. Well, it says what is the best action? So best action means there's one that's better than the other. And honestly, notifying the surgeon is better than not notifying the surgeon, because if I do B, that means I'm not going to notify the surgeon, right? And I really don't feel comfortable not notifying the surgeon. So I'm going to cross off B as not as good as A. Increase the client's oral hypoglycemic dosage per sliding scale. Well, if I do C, that means I'm doing it on my own. Well, I do have a sliding scale, I guess, but it means I'm not going to notify the surgeon. And I really want to notify the surgeon. And I've never seen a sliding scale for oral hypoglycemic meds. I've never seen it. So that doesn't seem practical to me. Like if I just use my common sense, that doesn't make sense to me. We usually give insulin on a sliding scale. We don't give oral hypoglycemics on a sliding scale. So C doesn't seem as good as A. Call the laboratory to repeat the glucose test before contacting the surgeon. So no, I don't like that. Let me explain to you why I don't like that. Because if they give you a number, the assumption is the number is correct. They don't want you to say, oh, I'll go ahead and repeat it and see if it's right. They're not testing to see if you know how to repeat a lab, if you know how to repeat a blood pressure, if you know how to repeat an EKG. That's not what they're testing. They want to know if you know what to do about this number. Okay, so we are not going to redraw it. There's no reason to think the 220 is inaccurate. They're type 2 diabetic. It makes sense to me. So I'm going to notify the surgeon, and we're probably going to have to give a little bit of insulin so they don't go too hyperglycemic. We don't want them to end up in DKA as they come, or HHS as they come out of surgery. The nurse is caring for a client who's 4 hours post-op from an abdominal hysterectomy. The client reports feeling short of breath. Which intervention should the nurse implement first? So 4 hours post-op from abdominal hysterectomy, and they report feeling short of breath. So that's a subjective finding. It's not objective. So I believe they feel short of breath. Do I need to do any further assessment, or do I need to do something? I don't know that I have enough information to do something. So let's see what the answers are. Elevate the head of the bed to a semi-Fowler's position. That sounds like a good idea. Call the physician immediately. I don't feel like I have enough information to call the physician immediately. I'd kind of like to know what their O2 sat is, maybe their respiratory rate. C, assess breath sounds and oxygen saturation. D, encourage the client to use the incentive spirometer. All right. I don't feel like I have enough information to do something yet. And I know that a lot of people are taught, oh, as soon as somebody feels short of breath, you should elevate the head of the bed. So that's not an across the board rule. That's not always the first thing you do. Like, it's a good intervention, but it's not always the first thing you do. And in this case, what they're testing is, do we have enough information to take action? And what I'm saying is, I don't have enough. It's a subjective finding. I need to have some objective data so I know what to do. Like, I need to know what to do because I need more data. So the best, or the first thing that I would do, is assess breath sounds and oxygen saturation. A client is scheduled for surgery and has a history of obstructive sleep apnea. Which of the following is the nurse's priority to prevent post-op complications? So priority is the same as best. So it means there's one that's better than the others, but I can only do one. I can't, it's not a first question. It's not like I do this and then this and then this. It's a best question, means there's one that's better than the others. Encourage the use of the client's CPAP device. Well, CPAP is used to treat obstructive sleep apnea. So they're scheduled for surgery. Which of the following is the nurse's priority to prevent post-op complications? So we're not talking about like during surgery. We're saying post-operatively. Well, if they have obstructive sleep apnea, it seems like using their CPAP would be appropriate. That seems completely just common sense, tells me that's a good idea. Offer frequent pain medications to reduce the stress response. Well, the stress has nothing to do with sleep apnea. And I want to answer the question that's being asked. They're specifically asking me about obstructive sleep apnea. So B is definitely not better than A. So far, A is still the best option. Provide extra pillows for comfort. Well, is pillows better than CPAP? Well, no, it's not better. Pillows is fine. Elevate their head a little bit, all that. That's all fine. But it's certainly not better than CPAP for sleep apnea. So A is still better than C. D, ensure the client ambulates early to expand the lungs. Well, that's a great idea to prevent other post-op complications, but it doesn't prevent sleep apnea. CPAP is the only thing that prevents sleep apnea. So make sure that you're answering the question that's being asked. D would probably be the only other one that would tempt me if I were just thinking about post-operatively. Like, if you were to just say what's important post-operatively, I would say, well, let's do cough and deep breathing and early ambulation. That's just generally, but this is specific to sleep apnea. So you have to answer the question that's being asked. The nurse is conducting a pre-op assessment for a client who will receive general anesthesia. Which finding is most important for the nurse to report to the surgical team before the procedure? All right, so I'm doing a pre-op assessment. They're going to get general anesthesia. The client smokes a half pack of cigarettes daily. The client occasionally experiences constipation. The client had a total hysterectomy 10 years ago, or the client reports an allergy to shellfish. Okay, so I'm going to read the question again. It's conducting a pre-op assessment for a client who will receive general anesthesia. What is the most important finding to report to the surgical team? All right, so let me go general. So let me think generally. So as it relates to general anesthesia, will smoking half a pack of cigarettes affect general anesthesia? I don't know how that would affect general anesthesia, so I'm going to put a question mark next to it. Will experiencing constipation affect general anesthesia? I don't see how that would. I'm going to cross off B. Would having a total hysterectomy 10 years ago affect general anesthesia? Well, the only thing I think about that is I think they've had surgery in the past, so I would want to know how they responded to anesthesia 10 years ago. So that seems like that might be something I would want to report to them. It seems to me like C, the fact that they've had a past history with surgery, might be more important than cigarettes. I mean, they could be withdrawing from nicotine, so maybe. I don't know. A and C are sort of both seem kind of like good things to tell them. D is make sure they know their allergies. So if I think about what is most important, it says most important to report. Is it important to report what their allergies are or something else? And then if it's something else, then I can decide what that something else is. To me, reporting allergies, that they have an allergy to something, is most important as it relates to surgery and general anesthesia. So I'm going to go ahead and pick that one. And that I had to think very generally with this one, because I don't specifically know if an allergy to shellfish affects general anesthesia, but I'm sure that they would want me to report allergies. Like, that just seems really important to report allergies. So that's because I went more general, I was able to get this one correct. A client is 1 day post-op following an open cholecystectomy. The nurse notes the client's urine output has decreased significantly over the last 8 hours. What should the nurse do first? So this isn't a best question. It's a first question. So open cholecystectomy. So what I think of is, well, they have an incision, they opened them up, they messed around a little bit inside of them. Increase the client's IV fluid rate to promote diuresis. Well, their urine output has decreased significantly, so maybe. Check the patency of the urinary catheter for kinks. Well, that definitely has to be done. Can contact the provider to report possible acute kidney injury. Maybe, if it's reduced significantly, I probably will want to contact the provider, document the findings, and recheck in 2 hours. Well, I would want to do that. It seems to me like they all might be, probably A wouldn't be first. I wouldn't think A would be first because I'd want to kind of check things out before I get all aggressive and increase their fluid rate. But out of all these things that are there, it seems like the first thing I would do is make sure the urinary catheter doesn't have any kinks. Remember, it's a first question, not a best question. Okay. So yeah, I got to make sure it's draining okay before I do anything else crazy. The nurse is reviewing meds with a client who is scheduled for surgery in the morning. Which med might the nurse anticipate holding on the morning of surgery after notifying the provider? Beta blocker for hypertension, proton pump inhibitor for GERD, aspirin for coronary artery disease prophylaxis, or anti-epileptic for seizure control. So what you don't want to do is say, well, I thought we'd have to hold them all. We obviously don't have to hold them all because they're not asking us if we'd hold them all. They're asking us which one would be really the most likely to be held. So if they have hypertension, they're going for surgery. If I give them the beta blocker before they go, it'll help control their blood pressure while they're in surgery. That seems like fine. I'm fine with that, having a beta blocker on board while they're in surgery. Proton pump inhibitor for GERD. They're going to be flat. They're going to be intubated. Probably, it doesn't say that, but they might be intubated. At least they're going to be laying flat. So if they have GERD, they could certainly have some reflux. They could aspirate. It seems fine that they could have a proton pump inhibitor. There doesn't seem a contraindication to me. Aspirin for coronary artery disease. All right, aspirin. Is that going to do anything as it relates to surgery? Well, it's not going to prevent anything specifically during surgery, and it could cause, it's an antiplatelet, so it could cause them to bleed a little more than you would expect them to during surgery. So it seems like aspirin may need to be held. Anti-epileptic for seizure control. Well, I certainly don't want them to have a seizure during surgery. So I'm fine giving them their anti-epileptic, but the aspirin, it seems like it could increase their bleeding. So if I were to anticipate which one I would hold the aspirin. And if you say, well, we always hold the aspirin. Well, we pretty much always do hold the aspirin, but that is a provider decision. So what we say is, instead of saying we always hold the aspirin, say, well, I would anticipate holding the aspirin. It's not my decision to make, but I would definitely, if they didn't have an order to hold the aspirin, I would definitely contact the doctor and go, hey, you want me to hold the aspirin? Because that's what we usually do. A client has returned from the PACU after a hip replacement surgery. Which assessment finding requires immediate intervention by the nurse? They've returned from the PACU, So they were in the PACU and now they're out on the floor, sounds like. Okay. So they're complaining of pain at 8 out of 10 at the surgical site, which requires immediate intervention. 8 out of 10. Blood pressure of 100/60 with a pulse of 88, surgical dressing with a 1 centimeter diameter spotted drainage, or capillary refill of 5 seconds in the operative leg. So I would always say the thing that I'm most concerned about, the thing that I would contact the doctor about, the thing that I would intervene immediately for would be the unexpected finding. So we have one patient with one problem, and then all the symptoms are in the answers. And remember, when you have one patient with one problem and all the symptoms are in the answers, and you have to decide which one you're most concerned about or which one requires immediate intervention, you always choose the one that's unexpected. So is it expected or unexpected for them to have pain? Well, I'd expect them to have pain. They just had surgery, but it's 8 out of 10. Well, that's a subjective finding. They say it's 8 out of 10. Fine. Fine. It's 8 out of 10. That's okay. All right. I expect it. Blood pressure, 100/60. Well, the MAP, so the systolic's not under 100, which sometimes makes me wonder, but the MAP is over 65. So the mean arterial pressure is fine and their pulse is fine. So I'm okay with this blood pressure. Surgical dressing site has a 1 centimeter diameter spot of drainage. Well, I'm going to keep my eye on it. I might draw a circle around it, but I'm not going to do anything about that yet. I got to see what happens with that. So I got to keep some idea of, and watch the trending of if that gets bigger. So I'm not going to do anything about that now. Capillary refill is slow in the operative leg. Well, if the capillary refill is slow in the operative leg, it means it's not perfusing. So that's definitely unexpected. I would expect to have good capillary refill in the leg that had the hip replacement. Otherwise, something's wrong. The nurse is preparing to administer pain medication to a post-op client. Which assessment finding requires the nurse to hold the medication and notify the provider? So I'm planning to give pain med. So what is a contraindication to a pain medication? Well, I'm looking for a contraindication, right? That says this is not safe to give if they have this thing. So let's see. Client's respiratory rate is 10. Can I give pain med when the respiratory rate is 10? Well, normal is 12 to 20. Primary side effect of pain med is decreased respiratory, right? So I don't think that's a good idea to give pain med with their respiratory rate is 10. Client rates pain of 8 on a 0 to 10 scale. Well, no, I definitely need to give the pain medicine then. They report drowsiness. No, that's okay. They can be drowsy and I can still give pain medication. Doesn't say they're confused. They're just drowsy. That's okay. They have a normal blood pressure. No, that's fine. I can give pain medicine when they have a normal blood pressure. So the only one is they have a slow respiratory rate because pain medication will slow respiratory rate. A client who is 2 days post-op after an abdominal surgery presents with a mild fever, mild abdominal pain, and diminished bowel sounds. Which action by the nurse is most appropriate? So the question is that expected or unexpected? They have abdominal surgery. So would I expect them to have a mild fever? Well, if they were getting pneumonia, it would be more than a mild fever. If they'd left something in their body during surgery, it would have been more than a mild fever. So a mild fever, that's just to me, I would say that's probably expected because the body does have an immune response when they have surgery. I mean, the body interprets that as an assault on the body, and it does stimulate the immune system. So actually having a low grade temp after surgery is not that unexpected. They just had abdominal surgery, so they have pain. So that seems okay. And diminished bowel sounds. I don't know what surgery they had, but usually after abdominal surgery, they do have diminished bowel sounds because we mess around in their gut. It irritates the bowel and it often slows peristalsis a little bit. It doesn't say they're gone. It doesn't say they're absent. Now, if they had absent bowel sounds, y'all, I'd call the doctor about that. I'd be concerned about that. But it's just diminished. So I don't know. I mean, it doesn't seem, I'm not that concerned. So let's see what the actions are. Encourage ambulation to promote peristalsis. Oh, I like that. So what I'm thinking is, yeah, we've had some slowed peristalsis. The body's having an immune response. I expect him to have some pain, but I do want to get going again. We want to get that going. So yeah, ambulation is a great thing to do. Call the surgeon to report a possible infection. No, that temp's not high enough to report a possible infection. Increase the IV fluid rate to cool the client. No, that's not how we cool the client. Withhold oral intake until the bowel sounds return. No, absolutely not. Now, if it said they had absent bowel sounds and they were not passing gas, then I'd call the doctor and go, there's a problem here. But they've just got diminished bowel sounds, some mild pain, mild temp. I'm going to get them up and walk them around. So what this question is testing you is, hey, can you assess some expected findings after surgery? And then what are you going to do about it? Because that's our job as a nurse, right? To figure out what's going on and how do we intervene. It doesn't mean we have to get all worked up, but we want to. It's like if you assess crackles in the lungs, what are you going to do? You're going to do coughing and deep breathing. You're not going to call the doctor about crackles in the lungs post-operatively. You're going to do coughing and deep breathing. If you have decreased bowel sounds, you're going to do ambulation to try to get them walking again, right? So it's the difference. And I don't mean crackles through the entire lungs, but like crackles in the bases post-operatively. So you have to be able to use clinical reasoning and common sense to say, is this clinical scenario something I have to really be aggressive with? Or can I do some of the standard typical post-op interventions that we do for anybody after surgery? The nurse is preparing discharge instructions for an older adult client who is post-op day 3 from a hip replacement. Which instruction is most important to emphasize to prevent complications? All right, so they had a hip replacement. Use a reacher or adaptive device to pick up objects. Well, they didn't have a problem with their arms. This isn't an arm problem. I don't see why that would help. Maintain leg abduction using pillows while lying down. So adduction is bringing your hips, legs together. Adduction is bringing together. Abduction is separated. And I know with hip replacement, you can never cross your legs again after hip replacement ever. And post-operatively, you do want to keep your leg, the hip that was replaced, abducted. So out. You want to keep them separated. So that seems like a good idea. Try light exercise such as short walks twice a day. They just had hip replacement 3 days ago. Y'all, they're going to be like maybe walking to the bathroom. They're not going to be doing that. They're going to be using like major assistive devices. They got to learn how to walk again on that hip. Keep the incision dry and change the dressing daily. All right. I like D. They may or may not need a dressing change, though. We can keep it dry without doing a dressing change. In fact, a lot of times they take the post-op dressing off and don't replace it. It really depends on if it's having any drainage. So I do need to keep it dry and change the dressing daily. So I'm going to cross off A and C. B or D, it says, which is most important to emphasize. So I can only do one. Most important is the same as best. So I'm going to make sure they keep their legs abducted, but I'm not going to teach them how to keep the incision dry and change the dressing, or I'm going to keep the incision dry and change the dressing, but I'm going to let them adduct their legs. Y'all, I'm not going to let them adduct their legs after hip incision. Absolutely not. So the most important thing here to emphasize is B. Now remember, best questions, highest priority questions, most important questions. These are theoretical. It's never true that we can only do one thing. Like that's never true, right? So don't go, well, I would never do just that. Yeah, I know you would never do just that. But what they're testing you is a fundamental principle. What is the most fundamental principle to know about to teach a patient after hip replacement surgery? It's that you can never cross your legs. Like that's really fundamental. And they want to know if you know that. A client arrives on the surgical unit after a thyroidectomy. Thyroid is in the neck. It's part of the endocrine system. There's two lobes to the thyroid. You can have a partial thyroid where you only remove one lobe, or a total thyroidectomy where you remove both. If you remove one lobe, they're at risk for thyroid storm because that thyroid that's left can start to rev up. If they do the entire thyroid, then the risk is that they can remove. Well, if they remove the entire thyroid, they're going to have to take thyroid hormone for the rest of their life because don't have any. But you're also at risk to remove the parathyroid, and the parathyroid controls calcium. Okay, so all right, the client arrives on the surgical unit after thyroidectomy. It doesn't say total, but since it doesn't say subtotal, I'm going to assume it's a total. Which of the following findings would indicate a potential complication requiring immediate intervention? A small amount of serous sanguineous drainage noted on the dressing. No, that's okay. That's expected. Hoarseness when speaking for the first time after surgery. Well, they just did surgery around the neck. They would have intubated them for this surgery. It's a pretty major surgery. So it doesn't, I'm not too concerned about hoarseness. Now, if they have striders, right? That's stridor. Now I'm concerned about that because that's a narrowed airway, but hoarseness, no, I'm not too concerned about that. That's not that atypical after they've been intubated. Elevated temperature of 100.4 on arrival to the unit. It's a total thyroidectomy, so I'm not watching for thyroid storm. Thyroid storm, I'd be concerned if the temperature was over 104. This is 100.4, so it's not very high. They're having an immune response to the surgery, so that's pretty expected. Tingling around the mouth and the fingertips. All right, tingling around the mouth and fingertips is paresthesia. Paresthesia is associated with hypocalcemia. Remember I told you when you remove the thyroid, the total thyroid, you're at risk for removing the parathyroid, which controls for calcium. And if you accidentally, unintentionally remove the parathyroid, which happens because it's really hard to separate out from the thyroid. So if you accidentally or unintentionally remove it and they become hypocalcemic, they're going to have paresthesia. So that is my biggest concern. So I would be concerned that they're becoming hypocalcemic, and that would be my biggest concern for that one. Well, I don't know. I hope that helped you. I hope that helped you. It is pretty common to get thyroid questions on the NCLEX. It's also common to get pre and post op questions. So these are just some general questions to challenge you to think clinically, to use clinical reasoning and common sense. Y'all don't forget your common sense. So have a great rest of your day. Thanks.